patient who was scanned elsewhere. It's not a machine that I'm familiar with, but I asked for the clip to be displayed, and it's a very nice clip which they kindly shared with me. So the descending aorta is here, and when you look on 2D, you can see that on 2D that there's very little contractility of the left cardiac ventricle. You can see fibroelastosis, and that you can see that the apex of the heart is actually not formed by the left ventricle, it's formed by the right. And that's an important thing. Part of a routine assessment is when you're looking at the heart, the apex should be formed by the left ventricle. So these are and then we look with color Doppler examination, and we look to see if there's any inflow into the left ventricle, and then you want to know, is there any flow across the aortic valve, and you see reversal of flow. So you have a combination of mitral atresia, aortic atresia. So I get a phone call to say, Simon, we have a baby with a hypoplastic left heart syndrome. And I said, yeah. And he said, well, the reason I'm ringing you is because I just want to let you know that she had a scan with you when she was 13 weeks at Monash Ultrasound for Women. And I said, really? I said, yeah, I did. And I said, okay, well, let me just go back and have a look. So anyway, I went back and had a look. Of course, the first thing is when you get a phone call like that, you say, who did the scan? So, because there's 5 or 6 doctors in the unit, and we've got a whole series of sonographers, and he said, who did the scan? So I ring the secretary and said, who did the scan by the way in this lady? She was seen about it. So you did. And I said, did I really? Okay. So that's where you begin to panic. And you then go back and you have a look and you say, okay, well, how do things look at that stage? And I sort of was firstly reassured, and I said, okay, well, that looks like a pretty normal looking nuchal translucency. And then I go back and I say, okay, well, how do things look when we looked at the 4-chamber view of heart and atvotrax? And when I say, that I did this scan, there's a little bit of blarney thrown in there. It was one of my sonographers, CF, who did the scan, and I was delighted with her and congratulated her on how she produced a 4-chamber view of heart and a 3-vessel view, and I was very reassured by that. And for every scan that we do in the unit, we request or we archive is that not just the 2D images and color images, we record a cine loop. So these were her 3-vessel tracheal view at 13 weeks and 1 day. And she also did go to the LVOT again. That's not part of the ECR guidelines, but we do look at the left ventricular tract simply from the point of view of the co-truncal abnormalities, that we want to see if there's any co-truncal abnormalities. And this was the cine loop in this patient with a hypoplastic left heart at 13 weeks. So here we're talking about somebody who's literally 7 weeks earlier who had a scan, and then she went the extra mile and she looked at the pulmonary veins to see if there's any evidence of any bidirectional flow in the pulmonary veins. She also looked at the great vessels, and we had a completely normal scan. So this was a fetus with a hypoplastic left heart who, when we went back and had a look at it and said there was absolutely not a single skerrick of information on the scan when she had the first trimester of pregnancy. And in a sense, you talk about, will ultrasound in the first trimester ever replace ultrasound in the second trimester? Well, the answer, of course, that we all know is no. But if you want to take examples of that, in a sense, is, a lot of it relates to valvular lesions that sort of... Yes?
Giolini doesn't think it was normal.
No, say again?
Can you put the image back? No,
you didn't show? Didn't come up?
Can you put the image back if you don't mind?
This one?
No, the one that you have.
Giolini is spoiler.
The left ventricular. No, I think.
I have a feeling I'm going to get axed.
No.
Let's have a Guinness.
I think from the screening.
Sorry, Giolini.
From the screening point of view, this is excellent. In retrospect, I can't quite read the velocity there on the scale. What's the scale for the velocity? And if you, particularly when you had...
On the clip or on the
color flow velocity?
36.
Yeah, on the one that you had the...
flow, the cine loop.
This one. What's the velocity when you have... Because it looks as if you have some aliasing in the aorta.
Oh, I see. Well, let's go to the clip.
No. I want to see the scale on that one that had the aliasing. Yeah, you see a bit of aliasing there in the aorta. What's this? I can't read the scale, the color scale. Can you
44.
tell me what it is? Yeah, so in retrospect, as I said, from the screening point of view, that is a bit of aliasing in the aorta. So
but that's not a transverse section. I'm not catching an LVOT in that section.
No,
there. Ah,
yeah.
but that's a trans... Yeah, I agree with you. In a critical aortic stenosis, you see yin-yang.
I'm trying to be critical.
I agree in a scenario
If
of a
you-
critical aortic stenosis, you will get that slight dilatation, the yin-yang appearance.
If I were doing a scan at 13 weeks, for
Yeah.
whatever reason, I'm
Okay.
doing a complete fetal echo, I would measure all the velocities.
Yes.
That's what I'm saying. From the screening point of view, this is excellent screen. There's nothing to be blamed about it.
Yeah.
But if you present it here with that heart, I think this is the clue that if you had measure, or if someone had a reason to measure the velocity across the aortic valve,
Yeah.
I suspect the aortic velocity would have been increased. You would have very mild aortic stenosis at that point.
I mean, I think it's always easy with the benefit of hindsight. When
I
you come
said
back and look
that.
at
I
these
said
cases.
that in retrospect. I said that.
Yeah.
I'm not blaming anyone. I'm just trying to see why is it that you had a hypoplastic left heart at 20 weeks. That started with aortic stenosis. Yeah.
Yeah, I take your point. And in a sense, the population of patients that we see is thousands upon thousands of low-risk patients, and we have to pluck out the needle out of the haystack. From a pediatric cardiologist's point of view, you spend 30 years of looking at the needles that come out of the haystack. So when you're actually in the haystack looking, at not the needles, you have so many variations that will show you differences in color distribution in different chambers on different PRFs and different probes. And for us, we have to pluck that needle out. There are so many challenges that exist in the world of the haystack before the needle is delivered to the pediatric cardiologist. So when I go to the sonographer and I come back to these images, I won't be giving her this feedback and saying there was a yin-yang appearance in the aorta. Next time I want you to pick it up.
That's not what I said.
Sent an email to her and I said,
Simon, don't worry, I'll bring you food to the jail when you go to jail.
Anyway, so because there's another case, Giuliani, and I'm a feeling that I'm under the hatchet again on this one here, but let's see how we go.
I won't be invited to the next meeting.
No. Debate's absolutely critical, and I think it's important we share our views and put it on the table. Otherwise, it'd be desperately boring if we were all to agree with each other. So in this case, is a patient who's at 13 weeks of gestation, or 12 weeks and 6 days in gestation. So if I go back, actually, sorry, I've jumped the gun. So this is a patient at 21 weeks and 3 days of gestation on the 28th of March. And this is showing a four-chamber view of heart. And you sweep from the four-chamber view of heart up to the three-vessel view. And I ask you the question, what do you think's going on? So I ask you, one, is it an Epstein's, tricuspid valve dysplasia, pulmonary atresia with intact septum, tetralogy of Fallot with pulmonary atresia, absent pulmonary valve syndrome, or polyvalvular dysplasia? So it's a long, lengthy differential diagnosis. And I just very quickly, in the interest of time, walk you through and say you're obviously not happy with that fourth chamber because you're seeing there's really quite significant regurgitant jet. And then you ask yourself, when you see the regurgitant jet, you then sweep up to the right ventricular outflow tract, you ask the question, is there flow across the pulmonary valve? Now, this is a very important basic thing, is you may have a completely normal-sized pulmonary artery, but if you don't have flow across the valve, that is pulmonary atresia. So the pulmonary atresia, I'd always started off when I was learning, I thought pulmonary atresia, you've got a tiny vessel, you can't see it on scan. No, yes, well, that may be one type of pulmonary atresia, but this baby, there was no flow across the pulmonary valve. And that's a critical point when I go back to looking at the right ventricular outflow tract, is you have to have the right free wall in view, you have to see the pulmonary valve, you have to ascertain, is there flow across it? You can't just jump to three-vessel tracheal and say there's a reversal of flow. You want to know, is there flow across it? So this is a patient who is at 21 weeks, and I find out, where did she have her scan done? She said, well, actually, she had her scan done with us because we saw her in the first trimester. And this is her at 12 weeks and 6 days. I mean, you look at the four-chamber view of heart, you look what appears to be normal movement of both of the valves, a baby who's got a thin nuchal translucency. When I go back and have a look at the four-chamber view of heart, I see normal inflow, and as I look at that right AV valve, I don't think there's a hint of tricuspid valve regurgitation. If I then go to the image looking at the three-vessel, because I say we archive clips of outflow tracts, and then when I look on that, I can't see there's a skerrick of, there's no suggestion that there's no flow across that valve, and I can't see any evidence of turbulence across the valve. Giuliani, do you agree with me?
I can't read the scale.
She doesn't give up, does she? 34 centimeters.
Yeah.
Quiet over there.
I think you may be getting alias in there because of the duct, yeah? It's quite you do have some alias. If that is across the valve, if that's across the duct, which would be normal at that velocity.
So if I come up to here, this is the duct.
That's the alias in there, it's in the duct. Yeah, there is forward flow, no question.
Okay.
There's a sparkle there across the valve.
Okay. All right.
If you go slowly,
yeah.
you've chosen the wrong cases to show.
Okay, I've got to finish in the last case in the interest of time. And this just shows you how life can be difficult. As Rabbi says, it's like a box of chocolates. You never know what you're going to get. And this is a patient, again, a very recent scan. You start transabdominally, and you just find, it's sort of the case, you look at that heart and you say, oh, what's the point? And you say, you know, I went to talk in first semester diet. Well, look at that. That's what I'm seeing on Monday morning. I haven't a hope in hell. I actually can't, I can see that there's a heart motion, but I actually can't see, in a sense, a fourth chamber. And in a sense, this is the whole thing about first semester, is you can't give up. So you just have to persist. And now you're persisting with 2D. So you go to the next step and you start with the basics. And you ask, is the stomach on the left-hand side? You do your split image, you store it. And then you try and get a four-chamber view of heart. So if you're struggling, as always, in the first semester, you then got the option of turning on color. But as I look at that four-chamber view of heart, the chamber closest to the descending aorta, the left atrium, I can see a left ventricle, and I sweep up there to the three-vessel tracheal view, and I see a big vessel. But really, in the first semester, I'm only going to get my answer if I start looking with color. Now, the strangest thing when I start looking with color, I see this filling of the atrial appendage. Now, that's not something that you normally see in the first semester of pregnancy. What I am seeing when I look at color, I've got my descending aorta, I can see this fill of the left ventricle, and I can see nothing going across on the right side. It looks like there's just a bar of tissue, and I can't see any flow going across the right AV valve. So that's the point in time where I'm saying, well, I should be seeing, with this degree of magnification, with my PRF setting of 24 centimeters a second, that I should be seeing some flow into the right ventricle. So then the next step is I magnify the image, I increase my dynamic range, and now I can see flow across the left AV valve, and I can see what looks like a large VSD, and what looks like to be a right ventricular chamber, but no flow across the right AV valve. And in a sense, the point that Bev made is when you have the scenario of a tricuspid atresia, the size of the VSD will determine whether you're going to see your second vessel or not. So in this case, when I look at that, I say, well, that's a good size ventricular septal defect. So I now want to know is if that's the case, is where is the second vessel? So I now move from my four-chamber view of heart up to the three-vessel tracheal view. Now I'm going to ask you a question. Can you put this together? So you see the flow inside the left ventricle, but when you sweep,
Of course you can.
you see this concavity of this vessel, and you see if this vessel, you ask yourself, well, this is coming out of the right ventricle. And this is where it becomes so important to understand. When sweeping from the right ventricle up to the caudal cranially, is you should get the vessel coming out of the right ventricle sweeping in the opposite direction. So I'm only seeing two vessels on the three-vessel tracheal view is the first problem. And the second problem is that I have reverse convexity of that vessel. And what does that tell me? It tells me the vessels are transposed. So I have no flow into my right side. I have two vessels on the three-vessel tracheal view. I now want to rotate my probe, and this is when I use slow flow technology because I really couldn't demonstrate it that clearly when I looked with color Doppler. So when I put on with slow flow technology, now I see both vessels coming out. And this is exactly one of the cases that Bev spoke about, that scenario of tricuspid atresia with VSD and the size of the vessel determined by the VSD. And they were good-sized vessels that I could see because the VSD was so large. But in a sense, we come back to a scenario at the end of the day, if you still have two good-sized vessels, right, we're still at the end of the day looking at a univentricular repair, right? Yeah, no matter what. Okay, I might stop there, and thanks very much for your attention, and we will regroup. Thank you. And thanks to all the panelists. And we will regroup. What time are we here? 4:30. 15 minutes break? Yeah, just a short break, 10 minutes.